madam?
Doctor, we are live now.
Yeah. Madam, can you stop the screen share?
I'm
Manjula,
trying to
can you-
come back to the
Manjula ma'am,
main.
can you help stopping the screen share?
Okay, doctor, one second.
Got it. Got it.
Yeah,
Done,
perfect.
right?
Yes, yes,
Yeah,
ma'am.
yeah, perfect. Right. So let's start the journal club with the team Retina, AMD, and its management. Today, here we are. So before we start today's journal club, the YOSI Journal Club publish or perish a call to action. As you can see, this has been one of the brainchilds of Dr. Sonal Kalia ma'am and Dr. Nupur Goyal ma'am, and Anujit was doing it for the last term. And this is a new term under the dynamic leadership of Dr. Divakant Mishra sir for the year 2024 to 2026, where the new term took over with a dynamic executive committee of 20 people and the PWG presidential working groups. So the concept of this YOSI Journal Club was to learn and grow. And you can see we have catered it from a young ophthalmologist. You could be a resident for a PG first year, second year, and third year, or for a fellow or for a YO consultant. So that's how we wanted to cater the journal club. And the journal club, which you can see, this was the definition of a problem, specification of the research question, defining the variables, selection of subjects, appropriate study design, analysis of data, interpretation of results, and the MAARIE format. And this was a format which our previous in charges like Sonal ma'am, Nupur ma'am have conceived, and we are following a similar concept with few minor additions, where the presenter, mentor, moderator, and the research expert with a dynamic panel is there. And you can see that the methodology, assignment, assessment, results, interpretation, and extrapolation are dissected in a step-by-step approach to read the medical evidence. And myself, I'm Dr. Prasanna Venkatesh, and after me, Niranjan is one who's taking a lot of efforts along with Anujit and Ayushi to make sure that this has been a huge success. They three form the skeleton, especially Anujit, Niranjan. They are doing tremendous work for the journal club team, along with the additional team of Arshi, Karthik, Rolika, and Samir. And if you are watching it, if you guys are seeing it, if you scan this QR code, you will get all our previous editions of Journal Club. And you can also be on the panel, or you can also be on the other side. Just send us a mail or connect to Dr. Naranjan or Dr. Anujit, or reach out to us, and we will be able to have you guys on the other side as well. It's an all-inclusive journal club. Anybody can be a part of it. You just need to mail us, fill in the Google Forms, or just reach out to us by DM, and we are there. So the history of Journal Club in 2021, you can see, my dear friends, we had 4 capsules on various subspecialties. Then in 2022, you can see we had 5 capsules on again various subspecialties. Come 2023, you can see the number of journal clubs increased to 7. And not only that, in 2023, we had the first IJO UC collaboration. So we had total 8 episodes with one collaboration with the IJO editor, and that was on biostatistics. In 2024, we had 6 subspecialty journal clubs, which our team, the new team, brought it under multiple categories: case reports, photo essays, original articles, managing plagiarism, how to avoid plagiarism, managing your references, approaching rejections, how do you approach your rejections. All these are there. Mastering research in survey designs and editorial insights, the untold stories of Journal Club, everything A to Z we covered in 2024. 6 with IJO and 4 with subspecialty. So we had around 10 in the last year of 2024 of refractive to glaucoma. And come 2025, we had 1 with IJO with biostatistics and 7 with the subspecialty, where Dr. Naranjan brought in the sponsors. So you can see from till March, we didn't have the sponsors. Till May, this became a financially viable event with sponsorships, where Microlabs is supporting the event from May onwards. And even during last month, when YOSICon happened, September 2nd, we had a journal club. 2 days before YOSICon, May, June, July, August, September, and we have had 8 activities in the last 8 months. And here we are for our 9th activity of the year. And this is going to be the one on Retina, and where we have again a keynote speaker, Dr. Monica Kapoor ma'am. We have a dynamic panelist team of Dr. Tanya, Dr. Isha, Dr. Samiksha, and we have our mentor, Dr. Shishir Varghese sir, and the new team up for this term, where we have again Dr. Shreya and Dr. Ritu, who are part of the journal club to convene and co-moderate it along with Dr. Niranjan, Anujit, myself, and Ayushi. So with that, I would like to hand it over to Niranjan to start the proceedings of this again. I think a marathon journal club that we have, along with multiple physical sessions that we had. So every event that YOSI has now, we have had a physical event in Meerut. We have had physical events in YOSICon. We have had physical journal club events again as RSTC, which Anujit coined as research skill transfer course in every YO pavilion that we get, along with the recently conducted one at Amritsar. So over to you, Niranjan and Anujit, to take it forward.
Thank you, sir. Thank you so much for the nice overview of our journal club activity. And we are very excited to welcome the new members of our journal club core, Dr. Ritu Singh, who's a very active executive member of YOSI, and Dr. Shreya Jain, who is also a very important component of our journal club session at YOSICon and a very active YOSI member as well. We are very happy to have you with us on board and looking forward to many more sessions together. So with that, it is my privilege to be introducing the speakers for today. So first up, we have, 1 second, let me quickly share my screen. Yes. So, yeah, is my screen visible?
No, Niranjan. Yeah, now, yeah.
Yes. So we have Dr. Tanveer, who will be the presenter for today. Dr. Tanveer Kaur, she's done her MS from Hassan Institute of Medical Sciences and her MBBS from Punjab Institute of Medical Sciences, Jalandhar. She has a keen interest in comprehensive ophthalmology and clinical research and has a strong focus on patient-centered eye care and surgical skills development. And she is very much an active member of YOSI and has several certifications from different ophthalmic and non-ophthalmic bodies. And to mentor her, who else better than Dr. Shishir Varghese? So, sir is a very well-renowned name in the Young Ophthalmologist Society and a very active innovator and a presenter across several conferences. So, he is a consultant vitreoretinal surgeon at Amita Eye Care, Tiruvalla, Kerala, and an ex-consultant at Arvind Eye Hospital, Coimbatore, with over 8 years of experience in vitreoretina, 45 plus PubMed Index publications, and 20 national and international awards. Sir, we are very delighted to have you with us as the monthly mentor. So over to Dr. Tanvi to present the article, after which we'll have the opinion from the panelists. We are also delighted to have with us our keynote speaker for today, Dr. Monica Kapoor. Ma'am, we are very happy that you accepted our invitation to be the keynote speaker. So, ma'am has completed her MS, DNB, FICO, and FAICO UVA, and is a fellow of Royal College of Surgeons, Glasgow. She's currently heading the Department of Vitreoretinal Services at the prestigious Netradama Super Specialty Eye Hospital, Bengaluru. And her areas of interest include learning and teaching vitreoretinal surgery, medical retina, uveitis, and retinopathy of prematurity. Ma'am, we are very happy to have you with us. And once the article is presented, we will looking forward to hearing your expert comments on that as well. Thank you. Over to Dr. Tanvi to start sharing her slides, please.
Are the slides visible, sir?
Yes, Dr. Tanvi. Please go ahead.
Okay. Good evening, everyone. Myself, Dr. Tanveer Kaur. I am a first-year PG resident at Department of Ophthalmology, Hassan Institute of Medical Sciences, Karnataka. First of all, I would like to thank YOSI for giving me this opportunity. So, we'll be discussing about the article. exploring the treatment options available for dry ARMD, titled A Vaccine Kept at Pegol for Geographic Atrophy, Secondary to Age-Related Macular Degeneration, 18-month findings in the GATHER-1 trial. The article was authored by Sunil S. Patel et al. And it was published in the Eye Journal in 24 March 2023.
Did you stop sharing, Dr.
Yeah,
Tanvi?
sir, that 1 second, sir.
Yeah, you just have to go to full screen now. We can see your slides.
So in this presentation, we'll be discussing about the introduction, aim, methods, results, discussion and critical appraisal, that is MARI. Coming to the introduction, age-related macular degeneration is a degenerative disorder in which the structure and function of macula is affected. It is characterized by the presence of specific clinical findings, including Dressen and RPE changes in the absence of other disorder. It is the most common cause of irreversible visual loss in industrialized countries. When we talk about the pathogenesis of AMD, we have various risk factors. For example, nutrient vitamin deficiency, advancing age, heart disease, obesity, UV and blue light exposure, genetics, family history, high blood pressure, high fat diet, light iris color, and smoking. The disease is classified into further subcategories depending on the presence of Dressens within 2 days of phobia in either eye. First is no apparent aging changes, that is no Dressen or no AMD pigmentary abnormalities. Pigmentary abnormalities are any definite hyper or hypopigmentary abnormalities associated with medium or large Dressen but not due to other known cause. Next is normal aging changes, where only droplets are present. Droplets are newly proposed term for small Dressen, that is less than 63 micrometers. The size of Dressen can be estimated by comparison with approximately 125 micrometer diameters of retinal vein at the optic disc margin. Then is the early AMD, in which medium Dressen size 63 to 125 micrometers are present and no AMD pigmentary abnormalities are present. In intermediate AMD, large Dressen of size more than 125 micrometers and any AMD pigmentary abnormalities will be present. In late AMD, we have neovascular AMD and or geographic atrophy. Coming to the main types of AMD, we have dry, non-exudative or non-vascular AMD. It is the most common form, comprising around 90% of the diagnosed disease. Geographic atrophy is the advanced stage of dry ARMD. It has been suggested that the term dry AMD should be used only to describe GA rather than the early stages of AMD. Next is the wet exudative or neovascular AMD. Is much less common than dry but is associated with more rapid progression to advanced sight loss. The main clinical entities are MNV, that is macular neovascularization, pigment epithelial detachment, retinal angiomatous proliferation, and polypoidal choroidal vasculopathy. Dry ARMD and GA. Again, it is non-exudative, non-neovascular AMD. Geographic atrophy is the advanced form of dry ARMD identified by irreversible loss of RPE, photoreceptors, and choriocapillaries. Activation of complement factors C3 and C5 plays an important role in the pathogenesis of dry AMD. GA threatens central visual loss in up to 5 million people worldwide, and in half of the GA cases, the disease progresses to both eyes within 7 years of initial diagnosis, showcasing the potentially severe impact on quality of life. Coming to the symptoms, the patient can have gradual impairment of vision over months or years. Both eyes are usually affected, often asymmetrically, and the signs in chronological order are numerous intermediate to large soft drusen will be present, which may become confluent. Further, focal hyper and hypopigmentation of RPE will be present. Sharply circumscribed areas of RPE atrophy associated with variable loss of retina and choriocapillaries. Enlargement of atrophic areas within which larger choroidal vessels may become visible and pre-existing Dressen disappear. We can do OCT, fundus autofluorescence, fluorescein angiography for diagnostic purposes. Main measure for disease progression is the lesion size, and the commonest imaging method is FAF. It is used in clinical trials to report lesion growth. This image here shows the presence of Dressen and mild pigmentary changes in the early stages of AMD. As the disease progresses, it is converted to geographic atrophy with well circumscribed margins of the atrophic patch. And this is the late FA image of the same lesion. This image shows the late stages of AMD with pigmentary abnormalities and geographic atrophy. FAF, it allows visualization of areas of atrophy and shows areas of hypoautofluorescence. Hyperautofluorescent zones, also known as the junctional zones, are present at the borders, showing areas at higher risk of progression to geographic atrophy. We can have different patterns on FAF in geographic atrophy, for example, none, focal, patchy, banded, diffuse, and diffuse trickling. Coming to management, we have to do prophylaxis by giving antioxidant supplementation if indicated. Risk factors should be addressed. Provision of low vision aids and visually impaired certification for individuals with significant visual loss, and potential new therapies, for example, complement inhibitors. Extrapolating these complement inhibitors, we have avacin captad pegol or ACP. It was approved by US Food and Drug Administration in August 2023 for the treatment of geographic atrophy. It comes under the brand name of Izervay and is available as 2 mg intravitreal injection. Avacin captad pegol or ACP is a C5 pegylated aptamer that is a short strand of synthetic DNA, synthetic RNA, which binds to the C5 complement protein. By binding to the C5 complement protein, it inhibits its conversion to C5a and C5b. C5a is basically a pro-inflammatory mediators which releases inflammatory cytokines, and C5b attaches to the C6, C7, C8, and C9 to form the membrane attack complex, which further causes membrane damage and cell loss. So ACP, by binding to the C5 complement protein, inhibits the conversion into C5a and C5b and further decreasing the release of inflammatory mediators and membrane attack complex. The GATHER1 study, it was an international prospective randomized double-masked sham-controlled pivotal phase 2 of 3 study of avacin captad pegol for geographic atrophy. Monthly intravitreal doses of 2 mg and 4 mg ACP for 18 months resulted in reduction by 27 to 30% in the rate of GA growth. Coming to the article proper, the aim was to assess the efficacy and safety of ACP, a C5 inhibitor for geographic atrophy, secondary to age-related macular degeneration over an 18-month treatment course. Materials and method. It enrolled 286 participants with geographic atrophy, and it was done across 63 sites, including United States, Europe, and Israel. It was done between January 2016 and October 2018. Inclusion criteria. Candidates with geographic atrophy more than 50 years of age with BCVA between 20/25 and 20/320 were selected. Non-center point GA lesion involving and in part within 1.5 millimeter of foveal center. Total lesion area had to be between 2.5 and 17.5 millimeter square, determined by screening FAF images. For multifocal lesions, at least one lesion had to be 1.25 millimeter square or larger. The total GA area had to be able to be photographed in its entirety within a 30-degree photographic field centered on the foveal center. Exclusion criteria. Candidates having macular atrophy secondary to any condition other than AMD in either eye, for example, in myopic degeneration or hereditary retinal degeneration, were excluded. Candidates must not have received any prior treatment for AMD, any prior intravitreal treatment for any indication in either eye, if any subtype of macular neovascularization was detected in either eye, if any ocular condition was present in the study eye that could progress during the study and potentially affect central vision or otherwise act as a confounding factor, if there was any sign of diabetic retinopathy in either eye. So the study was divided into two groups consisting of patients with geographical atrophy with their baseline GA lesion area noted from OCT, FA, colored fundus photography, and FAF, BCVA was noted and pattern of FAF was noted. The study was divided into two parts. Part 1 consisted of 77 patients and part 2 consisted of 209 patients. In part 1, the patients were randomized as 1:1:1 to receive monthly intravitreal injections of 1 milligram ACP, 2 milligram ACP and sham each. And in part 2, the patients were randomized as 1:2:2, that is, to receive monthly intravitreal injection of 2 milligram ACP, 2 milligram injection, that is total of 4 milligram ACP, and 2 sham administrations. Monthly intravitreal injection of ACP or sham were given for the duration of 18 months. The comparisons were made between ACP 2 milligram and ACP 4 milligram with their corresponding sham. GA lesion area was measured by FAF at baseline, month 6, month 12, and month 18. Outcome measures. The primary outcome was the mean change in GA lesion area at month 12 of the trial. The secondary efficacy endpoint was the mean change from baseline in BCVA, early treatment diabetic retinopathy study charts, and the low luminance BCVA. The safety endpoint was the incidence of adverse events and serious adverse events. Coming to the statistical analysis, all efficacy analyses were conducted for intent to treat population, which consisted of all randomized eyes that received at least one dose of study treatment. The analyses were repeated at month 18 using the same conventions as were prescribed for month 12. It should be emphasized that month 18 analyses were descriptive and not protected from a type 1 error, hence no p-values were reported to avoid any misinterpretation of the results. Mixed model with repeated measures were used. The primary efficacy analysis and 18-month analysis use the MMRM statistical tool to compare the treatment arms, which handled the missing data and dropouts fairly. So this slide shows the result. This is the 18-month endpoint analysis. Here we can see two graphs comparing the 2 milligram versus sham group and the 4 milligram versus sham group. The dotted line represents the sham geographic atrophy area in the sham population, and the black line indicates the 2 milligram ACP population. Here we can see 28.1% reduction in the GA area growth with a 95% confidence interval. And in the 4 milligram group, we can see 30% reduction in the GA area growth with 95% confidence interval. This table compares how much GA area increased across time at 6, 12, and 18 months. That is the mean rate of change of GA area by month. Here we can see with ACP 2 milligram group, at 6 months, the area was 0.123 millimeter, which progressed to 0.430 millimeter at 18 months. And with sham, it was 0.178, which increased to 0.599 at 18 months. Similarly, with 4 milligram, from 0.145, it increased to 0.391 at 18 months. And the percentage of slowing of GA growth, therefore, is 27 to 31% slower at 6 months with both 2 milligram and 4 milligram groups, and 25 to 28% slower with the 2 milligram and 4 milligram at 12 months, and 28 to 30% at the end of 18 months. This table shows the visual acuity results. It shows how vision changed over 18 months in terms of BCVA and LLVA with respect to the ETDRS letters. The BCVA loss with ACP 2 milligram group was 12.7 letters, and with ACP 4 milligram, it was 4.3 letters, and LLVA loss was 2.7 letters with ACP 2 milligram, and 4 milligram, a gain of 2.9 letters. So all groups lost some vision as is expected with GA, but ACP treated eyes lost slightly fewer letters, meaning a small vision preservation effect is present. LLVA is also slightly better with ACP. The difference is small but favors treatment. Coming to the safety analysis, intravitreal ACP was generally well tolerated over 18-month period with no ocular or systemic treatment emergent adverse effects related to the study drug. There was one ocular SAE, that is optic ischemic neuropathy with ACP 2 milligram, and one retinal detachment with ACP 4 milligram. The most frequently reported ocular adverse events were related to the injection procedure. This table shows the safety analysis results. Here we can see serious ocular events is 1.5% with the 2 milligram and 1.2 with 4 milligram group. Any eye-related adverse events were 58% with 2 milligram and 74% with 4 milligram group. The drug-related adverse effects were 0% with both the groups. There was no endophthalmitis, and one case of mild vitritis was noted with ACP 2 milligram group. The systemic adverse events were similar across all groups. So the 4 milligram group had slightly more adverse events due to higher injection volume, and overall the drug was safe and well tolerated. The next is macular neovascularization. The conversion rates were 11.9% with ACP 2 milligram and 15.7% with ACP 4 milligram, compared to 2.7% and 2.4% with their respective sham groups. The term MNV was used to refer to each three types of neovascularization. Type 1, when neovascularization is located external to RPE. Type 2, when internal to RPE or subretinal. And type 3, when arising within the neurosensory retina. This table shows the MNV incidence, that how often patients develop new abnormal blood vessels. In 2 milligram group, MNV incidence was 11.9%, with 4 milligram 15.7%, and with sham 2.7%. More treated eyes develop new blood vessels than untreated eyes. This is a known risk for complement inhibitors. And the fellow eyes had approximately 3% MNV in all groups. The difference is mainly in treated eyes. Coming to the discussion, the study showed 28.1% and 30% mean reductions in GA lesion growth over 18-month study for 2 milligram and 4 milligram treatment cohorts respectively, with continued separation from the respective sham cohorts when compared to the 12-month time point. In this study, the mean change in GA lesion area was reported as a square root transformation with an MMRM analysis to alleviate the effect of baseline lesion size on GA growth rate. The incidence of adverse events and adverse events related to the injection procedure was higher with the 4 milligram dose, most likely due to increased volume of the injection. The intravitreal ACP over 18 months was generally well tolerated, with no cases of endophthalmitis and only one episode of intraocular inflammation, vitritis, that did not result in study discontinuation. Increased MNV conversion was observed with 2 milligram and 4 milligram, 11.9 and 15.7 respectively at 18 months. Coming to the limitations, first, the macular imaging included color fundus photography, FAF, fluorescein angiography, and OCT, but it did not include OCT angiography, which was the novel ability to non-invasively detect the presence of MNV and determine its subtype. Second, it has been shown that distinct patterns of abnormally increased FAF in the junctional zone of GA have an impact on GA progression. In particular, the diffuse trickling pattern has relatively faster GA progression than other diffuse types. And lastly, a limitation inherent to clinical trials is the occurrence of missed visits and participants that exit the study prematurely, which could have potentially introduced a bias in the study. The GATHER2 trial. It is a randomized double-masked sham-controlled 24-month phase 3 trial, which is a post-hoc analysis. The eligible patients were randomly assigned 1:1 to monthly avacin captad pegol, 2 milligram administered as a 100 microliter intravitreal injection or sham for the first 12 months. Monthly ACP 2 milligram was well tolerated, showed significant slower GA growth over 12 months than sham treatment, suggesting that ACP might slow disease progression and potentially change the trajectory of disease for patients with geographic atrophy. In this table, we can see the difference between the GATHER1 and the GATHER2 trial. In GATHER1 was phase 2/3 randomized double-masked sham-controlled, and GATHER2 was phase 3 randomized trial. In 286 patients were enrolled in GATHER1 and 448 in GATHER2. 1 milligram, 2 milligram, and 4 milligram monthly injections were given in GATHER1, and only 2 milligram monthly injections were given in GATHER2. Duration was 18 months for GATHER1, and GATHER2 had 12-month duration. GA growth reduction was 28.1% with 2 milligram and 30% with 4 milligram versus sham, and 14 to 18% reduction was seen in GATHER2 trial as compared to the sham. GA growth, the square root millimeter per year, 0.43 with 2 milligram, 0.39 with 4 milligram, as compared to 0.60 to 0.56 with the sham. And in GATHER 2, we had 0.336 GA growth versus 0.392 with the sham. Visual acuity was slightly less with BCVA loss. Slightly less BCVA loss was present in GATHER 1 as compared to the sham, and no significant difference in BCVA and LL BCVA at 12 months was noted in GATHER 2. 11.9% 11.9% conversion to macular neovascularization with 2 milligram was noted in GATHER 1, 15.7 with 4 milligram versus 2.5% with sham, and 7% reduction with 2 milligram and 4% with sham was noted in GATHER 2. Safety, mostly injection-related adverse events were present, and were mild vitritis and no endophthalmitis was noted in GATHER 1. No endophthalmitis, IOI, or ischemic optic neuropathy was noted in GATHER 2. Only mild injection-related AEs were present. In conclusion, ACP slowed GA progression up to 18 months. Higher dose increased adverse events and conversion to MNV. ACP 2 milligram showed slowed GA growth, well tolerated. Pivotal trial supporting FDA approval. Coming to the Murray methods, international prospective double-blinded randomized control trial. The study was sponsored by Iveric Bio. The study population was well defined and the sample size was large. Assignment allocation was well depicted and it was a two-part study. Inclusion criteria was well defined. Exclusion criteria was well defined. Assessment, independent reading center and independent safety committee. Follow-up till 12 months. Primary endpoint and statistical significance obtained. Descriptive analysis at 18 months. Significance not obtained. Image analysis was independent, done by independent mass readers, so no potential for bias. Results was statistical analysis was specified and strength of study was not specified. Interpretation, ACP separation of the treatment arm versus sham at both 12 and 18 months with further widening at month 18. GA lesion growth significantly reduced with treatment as compared to sham. Rate of conversion to MNV was more with treatment as compared to sham, and safe molecule with only 1 millimole injection related adverse event was there. Extrapolation, ACP avacincaptad pegol is the only drug for GA growth reduction. Maximum dosage 4 milligram. Potential benefit in reducing GA growth. Increased risk of having MNV, warranting additional anti-VEGF treatment for the same. And insight into utility non-phobia involving geographic atrophy. Monthly injection and non-availability in India remains a challenge. Thank you.
Thank you so much, Dr. Tanvi. That was very lucidly explained, and I think you've done a fantastic job because dealing with such a new drug and very initial trials is not easy. I would like to invite Dr. Shishir sir to give his 2 cents on the article. For those listening in, just to repeat what Prasanna sir said. So, a mentee and a mentor sit for nearly a month with an article, and you can give us an idea about what you felt, sir, about the article and how easy or difficult it is for a resident to pick up something like this, as well as your thoughts on the article, and then we'll move on to the panelists.
Sure. Also, thank you, Dr. Tanvi. That was an excellent presentation. So this is one of the 2 drugs which is now available for treatment for dry AMD, that is the ACP. The other one is pegcetacoplan. So that came out slightly more earlier than the ACP. So they both act through the complement. The pegcetacoplan acts through the C3, whereas this ACP acts through the C5. So this is basically an RNA molecule with polyethylene glycol attached to it. That's why it's called ACP pegol. I mean, that's the pegol thing that at the end, and it increases the efficacy of the molecule and the time duration or the bioavailability of the molecule in the vitreous cavity. So this study is a pretty solid study, global, first of all, double blinded study, and also a randomized control trial with 2 parts. So why the 2 parts was my question there when they were doing the study. The first part, they used 1 milligram, 2 milligram and sham. That is basically to test the safety of how safe your molecule is before you actually, go and inject into a large number of population. So that's why they had those 2 parts, part 1 and then the part 2. The part 2 did 2 milligram, 4 milligram and then they did the sham. For every one sham patient, they injected in 2 patients so that more of the patients get the benefit of treatment when you're doing the RCT. Now they did a fundus photo, they did a autofluorescence, and they did the angiogram. The main purpose of the angiogram here was to rule out a macular neovascularization. But if they had an OCT angiography, which was not, they did not do the OCT angio, that would have been slightly more better. So only an FFA was done to rule out the MNV there. But here the prime modality of, seeing those GA lesions was the autofluorescence in this study. And then coming to the results of the study, now the thing is, this drug doesn't prevent AMD. It's not going to prevent or treat your AMD. It's not going to arrest your AMD. It is just going to, over a period of time, reduce your the time duration, or sorry, increase your time duration to get GA. Because like in any AMD, the endpoint is an atrophy. There's definitely got to be an atrophy. That's the primary endpoint of any AMD which you take, even if you treat it. So when you treat the with the ACP, the only thing is, if you are getting an atrophy at the fovea, in 3 years' time, probably when you inject this every monthly, you'll probably get it after 6 years later, or 3 years later, just to say as an example. So it's not gonna prevent your AMD, but it is just gonna reduce your increase your time to when you get atrophy. So that's the reason why, one of the reasons was they did not take any lesions involving the fovea, because if the fovea is already involved, there is no point in doing the study. So all the lesions which were taken were all extrafoveal lesions, where the edge is just abutting or just going to involve the fovea. So all were extrafoveal lesions, and only such patients will benefit when you take this drug. So the other issue is the monthly. The issues now, the BCVA is maintained. The patients, they lose, all of them, those who get treated, those who don't get treated, they will all lose vision. But if you inject the drug every month, they will lose slightly less vision as compared to the ones who are not treated with the ACP. So those are the two primary outcome: was the increase in the size of the GA, and the secondary was the visual acuity. How much letters are you losing? You're losing in the sham treatment or without treatment, you're losing quite a bit of letters, around more than 17, 18 letters. But once you treat them, you're losing only 12 letters with the 2 mg group. So that was the secondary outcome, other than the expansion of the geographic atrophy. Now, the issues with this is, one is definitely the monthly injection. Every month the patient has to come, take the injection and go. And the second thing which we saw was the macular neovascularization, which happened. Now there's only a hypothesis as to why it happens. They're not really sure exactly why it happens. But one of the reasons what they have said is that when the complement is inhibited, there is an increase in the VEGF load, which causes the macular neovascularization to happen. So higher the dose of the drug, if you're injecting 4 mg, higher rate of macular neovascularization as compared to the 2 mg, as compared to sham. So some patients with dry AMD, they will anyway go into neovascular AMD. But once you inject this drug, then you are higher chance of going into neovascular AMD. So if you look at so most of the dropouts, once they had MNV, they were all dropped out from the study. So at the end of the, the 18-month period, they had only 200 patients out of the 288 which joined, because quite a bit of them dropped out after the MNV. But if you look at the GATHER2 trial, the other one, those who developed MNV, they were also getting treated for the anti-VEGF. So that means if you treat with this drug, and if your patient will get it gets converted to a neovascular AMD, other than treating with this ACP, you're also going to inject him with anti-VEGF also. So if you look at the GATHER2, they did not drop out. Instead, they started treating them with additional anti-VEGF injections for the macular neovascularization. So that is definitely one of the major risks, as to when you inject this drug and when you gets converted to neovascular AMD, then it's double the problem. You're having to deal with the atrophy. You're also going to have to deal with neovascular AMD. Another third thing, that issue is the monthly injection was the first issue. Second issue was the macular neovascularization. Third is the cost. Now, the article doesn't mention the cost. Obviously, I mean, it's sponsored by this thing. But after little digging, I came across that the cost is around $2,100 for this ACP. And the pegcetacoplan, that is also around $2,190. That's the cost of this thing. And then they have a comparative study which they did, comparing the ACP versus the pegcetacoplan, and they found that monthly injections for a period of, a period of 2 years takes around $67,000, as compared to, just to spare 1 millimeter of atrophy going into the fovea. And also, so they also did once every alternate month. That's also comes to around $40,000 for a period of 18 months when you treat with this ACP molecule. And they said that pegcetacoplan is a little more cheaper as compared to this, but the risks of adverse events with pegcetacoplan is much more than the ACP. They have around 1.7% of optic neuritis. They also had vasculitis, retinal, similar to what we initially saw with brolucizumab drug. So, overall, a good molecule, definitely a hope for patients with AMD who are having a non-fovea involving atrophy, but always better to weigh the risk-benefit ratio, risk of developing NV, macular neovascularization. And second thing is the cost. Can your patient really afford? Is it really viable to use it in our setting or in our country? Yeah.
Thank you so
Over
much,
to
sir.
Dr.
I think you put things in grave perspective for all of us. We'll move on to the panelists. Dr. Ritu, are you there? Yeah, would you like to introduce the panelists? I'm just sharing my screen for you.
Yes, sir.
Just a minute. Uh, 1 second. Yeah.
I can share it from my end if
You can
there's a
share it from
glitch.
your end also,
Yes, sir.
not an
Yes,
issue.
sir.
Yeah, you can
Okay,
go
okay.
ahead and share it. So we'll be starting off with our 3 panelists, and then we'll be moving on to our keynote speaker. And while she's just sharing the presentation, we will start, I think, with Dr. Tanya.
Hi, hello everybody. Thank you for this opportunity and very, very well presented, Dr. Tanveer. I think Shishir sir has very beautifully summed up, the problems. So I'm going to share a little anecdote of when I was working in the US for about 6 months, and that is when these drugs actually started coming up. Even there, with the insurance and everything, all of the physicians were very, very cautious because of the three problems more with Syfovre, which is the other drug. Again, the problem is are these monthly injections. Second is the patient. So the perfect patient for this drug is a person who has an extrafoveal dry AMD or early geographic atrophy. They are not going to have a lot of symptoms. So it is very difficult to convince a patient with good vision that you will need very costly monthly injections. And if you actually see the table where they have shown the millimeter square of the geographic atrophy which is coming down even with these 18 monthly injections, it is like 0.02 millimeter with all these injections. So it is very, very few retinal cells. So we are obviously waiting for the very large, the longer term effects like 5 year or 8 year effects of these drugs. But right now it's very new, especially with our subcontinent where it is difficult to convince patients with wet AMD to follow up with, injections. So, but it is the need of the hour to treat, these conditions. A very good step forward. Yeah.
So may I continue with the
Yeah, yes, yes,
introduction?
please,
Yes, yes.
please. You can go
Although
ahead.
we heard the brains first before the introduction. Yes. So we just heard Dr. Tanya ma'am speaking, and she has done her DNB from Sadhguru Netra Chikitsalaya, Chitrakoot, VR fellowship from the Shroff Charity Eye Hospital, and advanced training also at the Stanford University of USA. Ma'am holds amazing record of research. She has 40 plus publications in the peer-reviewed journals, a speaker at national and international fora, involved in multiple clinical trials, and also currently associate editor of DJO. Thank you so much for joining us, ma'am.
Thank you.
We have our next panelist, and that's Dr. Isha Acharya, ma'am. Ma'am has an extensive fellowship training in VR surgery, ROP, and UVR from Narayan Nethralaya, Bangalore. A strong passion for academics, holding more than 25 publications in journals, including JAMA and American Journal of Ophthalmology, The Eye, etc. Ma'am has secured the Best Poster Discussion Award in the UVR Retina subspecialty in 2023 Asia Pacific Academy of Ophthalmology Conference. Adding to this, she also has won an AIOS International Hero Award 2 years prior. Ma'am, we can have your remarks now.
Thank you, everyone, and thank you, YOSI, for inviting me as a panelist in JC session. I remember I was a speaker a few years back, and now again I'm back in the JC as a panelist right now. Thank you, Dr. Anujit and Dr. Prasanna sir again for inviting me. So can I share my slides? I need to discuss some recent
Yes,
advances.
Yes, of course.
Please share your slides.
Right, is it visible?
Yep, it is.
Right. So, congratulations, Dr. Tanveer. It was an excellent presentation. And you have quite nicely explained what this article mostly suggests. And Shishir sir as well, he has quite intricately summed up the whole article as well as the Gather 1 and Gather 2 trials. So, as he has also mentioned that it was the Pexitaco plan that was first introduced and then followed by the ACP. And other than this, you might also come across two other drugs in the literature like eculizumab and lampalizumab. But the thing is, these two drugs are not FDA approved. So the main points of discussion were these two drugs, pegcetacoplan and the avastin captid. So the only major difference that we can see is the target component. That pegcetacoplan is something that is affecting the C3, that is the starting point. And from there, the whole complement pathway converts into a C5 complex. And that is how it goes on further. So if you compare the two drugs, it is the pegcetacoplan, which is having a broader aspect, broader inhibition of the whole pathway, while ACP is something which is more targeted at the C5 level. And the most important trials that were done in pegcetacoplan was the Derby Oaks and Derby trial, while the ACP we have all discussed. The mechanism of action was already quite well described by Dr. Tanveer. Once again, I would like to tell that how the pathway starts is from the C3 itself. So this is where the pegcetacoplan works, and then it converts into C3b, finally converting C5, and then the C5 getting dissociated into C5a and b to form the membrane attack complex. So ACP will affect the endpoint at C5 level, so that the membrane attack complex is not formed. Okay, so other than this, there have been quite a many trials going on since I think 2010 on the best eye drop for dry RMD. Unfortunately, we have not been able to investigate further on these, and we don't have any non-invasive eye drop to control the ARMD progression. So the few of the drugs that are mentioned are a fast blocking peptide, which is the most recent eye drop that had been introduced in 2024, but this was only utilized in rodents and rabbit studies and not in human trials. Then atorvastatin eye drops in the nanoparticles format has also been studied, but again, this is not in the market yet. And the last one being the OT551, which is a disubstitute hydroxylamine compound. So even this is not under functional right now. And okay, so other than this, we have some RP stem cell derived RP transplantation that is being studied by the Laksa Biotechnology. And even it has announced its results in phase 1 or 2A trials. So what do we see in this? Basically it's a post-mitotic adult RP stem cell derived RP transplantation. So when this was done, it is usually subretinally injected. And we found that there was around, in a worse seeing eye group, it had a 21 letters increase in the visual acuity. And in the better seeing eye group, it had a +3 letter improvement. So this is also under investigation, and we are still having hopes that something comes up as a treatment. Then these are some of the news articles that I came across in the modern retina. And I think Mira has been launched by Canada, a group, and it is a recent article. It was published just in 26 September 2025. So this is again some non-invasive tool that we are giving a 32-minute session using this Mira system. So what does it do? It delivers a low-dose micronutrient stimulation through the closed eyelids. And in this way, it is trying to stimulate the retinal cells, improving the mitochondrial function and hence the ATP production, further reducing the inflammation in such eyes. Other than that, there is a photobiomodulation approach for a dry AMD therapy. This was in a light sight 3 trial. Again, what we saw in this that we do a schedule of 9 sessions over 3 to 5 weeks. And then it is repeated again 3 times in a year or so. And this is how it also improves in dry RMD. And this is another thing that tells that when you see RMD eyes aqueous patients, we see that there is an iron transferrin imbalance. So ferroptosis is a well-recognized target in such cases. So they have come up with a pulse light LED therapy, which is PST611. So it encodes for a transferrin so that it can restore this iron balance and then prevent a dry RMD formation. This is a study that was already done by Lilac in 2022. And recently, again, they have published in 2025 that they are trying to treat the ophthalmic artery stenosis. So what they have found that if there is a stenosis, which is more commonly seen in aged people, that if such a thing is there in a person, that can lead to a chronic ischemic change and ultimately leading to choriocapillary deficit areas and causing geographical atrophy. So they've come up with a Ocudyne percutaneous transluminal catheter system where they're trying to treat this artery stenosis and see how the geographical atrophy improves. I think these are some of the extensive new literature that we are coming across, and I hope someday we find a good solution which is non-invasive, which has obviously more economical than what we are giving right now, and hope patients do have a hope in the near future. Thank you.
Thank you so much, ma'am. It wasn't just insightful for our PG resident here, also for us.
Right.
And Dr. Tanveer, make a note of the composite list, how ma'am has shown different compounds that target the complement, system. Because one of the questions this FAICO Retina was on Derby and Oak trials.
So eculizumab, lampalizumab was one of the questions in FAICO, so I thought to cover that.
Yes. So after hearing both positive remarks and the recent advances, let's move to a few negative remarks, which will be done by Dr. Samiksha Agrawal, ma'am. Ma'am has done her long-term VR fellowship from the Narayana Nethralaya, Bangalore, and is a scientific committee member, UPSOS. Ma'am has over 30 publications in many peer-reviewed journals, has conducted vast number of VR surgeries with more than 5,000 retinal lasers and intravitreal injections as well. She has had the opportunity to present over 70 presentations as both faculty talks and speaker talks at state, national, and international conferences. Dr. Samiksha is also an instructor at various programs of AIOS and UPSOS and currently serving as Retina subspecialty editor at the Uttar Pradesh Journal of Ophthalmology. Thank you for joining us, ma'am. And I'll stop sharing. If you have something to share, you can go ahead.
So thank you, Dr. Ritu, for the kind introduction. And thank you, Dr. Niranjan and Dr. Prasanna for having me here. So since I have been told to talk about few of the negatives, I don't have a PPT prepared for this. but certain things that we need to take into consideration in terms of India and in terms of Western countries. Like one of the speakers from the West, they used to tell that why all the anti-VEGF trials, there are three loading doses, and because they don't even see the patients in between. Like for the three injections, the patient takes the injection as a OPD procedure, and then they have a fundus camera where the picture is taken. Like not even an optom, not even a doctor, nobody sees the patient. They just get it recorded and they just take the injections, and after three loading doses, that's when the doctor sees them. So there's a lot of difference in terms of that, because that intravitreal injection is an OPD procedure for them. So that is one thing, and obviously financial aspect we have to take into consideration. Regarding some of the side effects like MNV, if we say that we are actually converting our dry AMD into a wet AMD, as you can say. So, you are giving monthly injections, and then you are converting it into, for the side effects per se, you are converting it into an wet AMD, and then in the second trial, which we all read, that they were giving anti-VEGF for that also. So in Indian scenario, it will be difficult for us to explain to the patient that you are taking an very expensive drug, and then because you have got the side effects of that, and now you have to take further anti-VEGF. So in wet AMD also, patient is not very ready, and they are lost for follow-up after 2-3 injections. So that is one thing we need to take into consideration, and obviously giving monthly injections, and they haven't taken visual acuity into consideration, because later patient will ask like, what advantage am I getting with that? So visual acuity is a big thing which patient needs. They are not going to see the picture of the geographic atrophy and saying that zero point 0.2 millimeter change is going to be there. So yeah, it is a very big thing, but then coming to India, I think it will take some time. So thank you. That's my remark.
They should do a real world analysis, like how most of the other anti-VEGFs towards the end have, other than the trials. Then you'll know the amount of people dropping out.
So,
Dr. Ritu, you can go ahead. Would you just like to share the screen and we
yes, yes.
can move on to the keynote speaker?
Um,
Yeah, you were just at that
I
slide.
was, yeah. So finally, we would like to hear from none other than Dr. Monica Kapoor, ma'am. She very kind of her to join here with us for the keynote speak. Ma'am is currently serving as the head of the Department of VR Services at Netradhama Super Specialty Hospital, Bangalore, and an avid learner and a teacher at her space. She is also serving as the medical retina and uveitis and ROP specialist at the same institute. So happy to have you here, ma'am. And you can go ahead with your screen share.
Ma'am, you
Dr.
can.
Monica, ma'am.
Hi,
Yes, yes, ma'am.
just
You're
in that
audible.
session. Can you see my screen now?
No, ma'am, we cannot see the screen. Ma'am,
Not
can you?
yet.
Now? Can you see?
Not yet, ma'am.
Not yet, ma'am.
Now?
No, ma'am.
No, ma'am.
Not yet. Um,
Ma'am, just unshare your screen, and when you press share screen, just click on share the entire screen or your desktop. And from there, you can go on to your presentation. Sorry. Yeah.
And we could see your screen briefly. You
No,
may.
that was. I
Okay,
was.
okay. All right, all right.
Is it
So,
now seen now?
yes,
Yes.
ma'am.
Ma'am,
Perfect.
can you just go into full screen?
Perfect.
Yes. Perfect, ma'am.
Okay, sorry about that. Hi, so first of all, I'd really like to thank the YOSI core team for inviting me. I'll be honest, I didn't know that you were doing such good work and having such journal club discussions and all. And it's really great to continue this, keep everyone updated and involved. So without wasting any more time, it's getting very late. I'll start with my presentation. Most of it has been covered before, but I just like to highlight some other points that were missed out. So first of all, I'd like to highlight the importance of dry AMD. So we are an aging population, and Southeast Asia is very densely populated. It is estimated that in around 2040, we will have 113 million people with AMD. So and also the late AMD is reported to increase from 3% at 70 to 9.8% at more than 85 years. So almost 9 to 10 people in every 100 are going to get late AMD, which could also mean a couple of us will be entering that group. So and that's where the importance for dry AMD lies. Now, as previously explained, AMD can be early or late. Early would be drusen and pigmentary changes, something as simple as this with a drusen. And late would include a macular neovascularization or even a geographic atrophy because of dry AMD, which looks like this. So this progression from the left side of the screen to right side is what I would like to focus on and see more clarity on that. So what are the prognosis related biomarkers that we need to be aware of? Of course, increase in drusen volume is a very important one and it's been there from a very long time. Now we should also know about decreased internal reflectivity of the drusen, intraretinal hyperreflective foci, subretinal drusenoid deposits, hypertransmission defects, BLAMDs, acquired or pseudo-vitelliform changes, and outer retina anomaly. So I'm just enumerating them, and then we'll see images of what they look like. So this is how we start with the normal OCT labeled as A, and then the drusens come in and B. With time, the drusens are going to change in morphology, increase. And these drusens then start to cause atrophy of the EZ zone and the ELM and land up in nascent geographic atrophy and then finally a geographic atrophy. So what are reticular pseudodrusens? These are basically drusen-like changes which are present subretinally above the RP and they are going inside. So these are very important predictors of advancing of the AMD. Another feature is the heterogeneous internal reflectivity within drusen, HIRD. So here, as the drusen starts to age, the internal reflectivity starts to reduce, and it may develop sometimes these hyperreflective changes. These are also known as calcified drusens, which are a predictor to advance AMD. On FAF, you will see them as hypoautofluorescent lesions. Another factor on the right, another feature that we see is if we look at the box that is highlighted there, there is the RP and the Brooks membrane, and there's some thickening in between the two. This is called the basal laminar deposits, which are also predictors of advancing AMD. Now a term called a nascent geographic atrophy. So that is basically just before the onset of a geographic atrophy. We have what is called a subsidence of the outer plexiform and the inner nuclear layer, along with disruption in the ELM and the EZ and hypertransmission defects below that. We can sometimes also see hyporeflective wedge-like lesions, in the Henle's layer, along with hyper transmission defects and shrinking or settling of the drusen's. So this is OCT image of one of our patients first seen in 2019. That's the lower one. And then again followed up, and the upper one is from 2024. We can see that with time, where the arrow is yellow, there we can see that the RPE and the Brooks membrane start to separate, and you have what is Blamdy depositions. Then there is where the orange arrow is, you can follow up and see there is some hyperreflective lesions that are coming up in the outer retina here. Also look at where the red arrow is pointing. Here we can see that the drusen settle down, and underneath that we can have a focal increased transmission that starts to develop. So these are changes that we will see when we start noticing in changes in our patients on sequential checkups. So the classification of atrophy meeting also classified the retinal pigment epithelium and outer retinal atrophy as a complete and a incomplete RORA. So complete RORA was defined as a hypertransmission of at least 250 microns, along with disruption of RPE of at least 250 microns, and with overlying photoreceptor degeneration. Anything which was not meeting this criteria was taken as IRORA. So this classification is primarily for research purpose, so that we have similar kind of unifying features when we talk about progression to atrophy or prevention of atrophy. So on this image, we can see that there is subsidence of the outer the outer plexiform along with the inner nuclear layer, and there's some disruption of the ELM and the EZ zone and increased transmission defects. The lower one is also showing the hyperreflective wedge bands very clearly. So what is the role of OCTA in dry AMD? Basically, it would be to differentiate any neovascular changes developing in a dry AMD. We can also see reduction in the choriocapillaries density before probably the onset of RP thinning and RP changes on OCT itself. Now, adaptive optic ophthalmoscopy is something that is newer. These allow high resolution imaging of retina at cellular level, and these show us individual photoreceptors. I'll share some of the images from Pinnacle study to help us see how AOO can help us in future. So just look at this image on the left. The upper one is a normal OCT, and the image below it is from the adaptive optics. The glass intrusions are going to be visible as isoreflective inside, along with a hyperreflective rim. So wherever the RP is intact, we'll have a hyperreflective rim. The smaller drusen's, however, have variable isoreflectance. Down below, we see what are SDDs. Now, these SDDs, when they have intact outer retina, will have this isoreflectance. However, when the ELM and the EZ starts to disintegrate, the lesions get surrounded by a hyporeflective ring. It also allows us to see the cone cells. So here we can see a poorly defined cone mosaic. Here, if we compare the image, here the hash signs, there is a very well-defined cone mosaic. On the lower image, it's just telling us about where to focus to look for the cone mosaic. This one is when the focus is on the retina, and this one is when we focus on top of the PED, we see the cone mosaic much better. So when it starts to progress to the AMD starts to progress, what changes do we see in AO? Like I said, as long as the RP is intact, we will see hyperreflective ring around the lesions. Once that starts to disintegrate, the drusen starts to become hyperreflective, and the ring around it starts to become hyporeflective ring. So this kind of tells us about the slow progression before these things are evident on the OCT. So this was about the imaging modalities. Now I'll come to therapeutics. Therapeutics, we have complement inhibitors, gene therapy, cell therapy, and photobiomodulation. Dr. Isha very nicely covered a lot of them and made my job easier. I'll just quickly run through them. So complement inhibitors are the final common pathway, like we all saw. So that's what is being targeted in most of these things. We have done a very detailed discussion on these two, so I'm going to skip that. Coming to gene therapy, why do we need gene therapy? Gene therapy basically we need because we want some treatment which is sustained and has localized therapeutic protein expression, something which reduces the need for repeated injections. Possibly one single dose, if we give, should give a very long lasting effect. Also, it will target the precise molecule. So where are we with the gene therapy? So there is the GT005, which was working on the complement factor I. Injections were being given subretinal, and the vector was adenovirus associated virus 2. Phase 1 and 2 trials were done. However, it did get approval for 2B, but the Novartis people discontinued it because it met the futility criteria, which means it's not basically worth investing into the development of this drug. However, we have HMR59, which is working at CD59, which also inhibits the formation of MAC. It is given as intravitreal injections, and here also phase 1 and 2 trials are done. Others are IXOVEC, working on complement factor H, and AAVCAGS CD55, which is also a complement inhibitor. All of these two are in a clinical state. Then cell therapy basically allows RP cells to be obtained and replace the degenerating retinal cells. It can be induced pluripotent cells or embryonic stem cells. Induced pluripotent cell transplantation has been seen to be relatively safe, with very minimal rejection, mostly controlled by topical steroids, and grafts are remaining stable up to 1 year, and has some minor complications like minor immune reactions or ERM formations. Embryonic stem cells, however, because of their ethical issues, we are not really able to explore them that much. Leading trials of stem cells are RG6501, ASP7317, which is using human embryonic stem cells to treat geographic atrophy. Now, eyesight RP is a pluripotent stem cell therapy, which is indigenous, in fact, Bangalore based, and got its approval in 2024 April for human trials. Now, coming to light-based therapies, this is something which is exciting because it's non-invasive and also can be given multiple times. So first, we'll talk about photobiomodulation. I think that was also covered. Mechanism is basically targets the photoreceptors mainly, and other cells would be RPE and choriocapillaris. It activates the cytochrome C in mitochondria, improves the energy metabolization, reduces reactive oxygen species formation, reduces complement activation, and thus enhances photoreceptor survival. Commercial devices are Valida light therapy, Lumithera, which has gotten approval in both US and Europe for use. The trials that were done were Lysite 1, 2, and 3. After the Lysite 3 trial, it got its approval. Now, it got authorized, not approved. So that means it is used as a adjunctive therapy, not a treatment. So it doesn't reverse anything. So main selling point would be that it is non-invasive and painless, short sessions. However, multiple sittings and cost issues are its limitations. And we also don't know about how long the effect will last. And if we don't give maintenance, it may start to degenerate again. Adaptive phototherapy is another experimental therapy that we are looking at. Basically, the idea is preconditioning. You give little bit light stimulation and cause reversible oxidative stress, which will then upregulate the antioxidant enzymes, heat shock proteins, and make the retinal cells more resistant to damage. Okay, so the other advances that we are seeing in AMD is the use of AI. AI has come into our lives in a big way now, and retina, especially because most of our diagnostics are imaging based. So it is helping in screening and diagnosis, so automated detection of drusen and pigmentary changes, geographic atrophy. Then there are AI models which can predict the geographic atrophy growth and risk of conversion to AMD. It can actually measure the size of the atrophy accurately over time and thus evaluate effect of cell therapy, complement therapy, and other photobiomodulation and other therapies. It may even help in future ophthalmologists in risk stratification and follow-up planning. Main utility could also be integration with smartphone and teleophthalmology for home screening and in underserved areas. So a lot has been published in AI tool for diagnosis. Nowadays, it's being combined with multimodality imaging of photos, OCT, Octa, everything being combined to see. So the challenges currently with AI would be regulatory approvals for clinical use, and most of these studies are Western population based. So we still need Indian models. How to integrate them into our workflow, our EMR, and a trustworthy module is probably something what we are waiting for to incorporate into our practice. In future, AI can incorporate OCT, fundus, genetic, lifestyle, and do a personalized risk scoring, and also help us in guided therapy selection, which patients are best suited for gene therapy, which for cell, which for complement inhibitors, etc. So I would like to end by saying dry AMD is now entering into a therapeutic era, and diagnostics are the main key enablers. Looking biomarkers, AI, home monitoring, and therapy options are also expanding now. We should start screening our patients much earlier and use multimodality imaging regularly for progress monitoring. Counselor patients now that treatment is possible or is upcoming. Stay updated. And because nowadays now the trials are going beyond complement inhibition, we have a lot more coming up. Now we were in the era of hopelessness. Now we are into the hope and in future we will cross the bridge and go into the action phase soon. Thank you.
Thank you so much, Monica ma'am. Loved the last line, how hopelessness to hope to action. This JC could not have had a better culmination. I would like to invite Dr. Prasanna sir to present the virtual felicitation.
Thank you, Ritu. Thank you, ma'am, Monica ma'am, for the wonderful lecture. So, do we have any panel comments or any discussion before we move to the last segment of the day? Shishir sir or any other panel, you want to add anything before we move to the last segment? Okay.
Yeah, great
Yes, sir.
presentation. I just wanted to say, and all good highlight on all the latest things. Only thing is, I just hope all these therapeutics or all these things are suitable for our population. West is developing quite a bit of this because the incidence of AMD is quite more in the Caucasian population. But ours also have it, and we also do need all these therapeutics. The only difficulty is how viable it will be for our population, because till now it also runs on how much the affordability is always an issue with these patients, and then they all also tend to drop out a lot more. Even if we tell them dry AMD, please come for 4-month follow-up or at least 6 months, couple of years they'll come and then they'll stop following up. They'll say nothing was wrong, everything was fine. So patient education and especially in our population, as well as highlighting the problem of this disease and then asking them to follow up properly is a big challenge. So hopefully AI and this screening will probably help in those kind of issues getting sorted.
Thank you, sir. So we have this very novel certificate distribution for our journal club, requesting all to switch on your cameras, and we would like to acknowledge with this virtual e-certificate which we have. Thank you, Monica ma'am, for your taking your time and being here as a keynote speaker, especially for this for our young ophthalmologists of YOSI. Thank you for your time and being here. Thanks to again Dr. Tanveer. So I think Dr. Tanveer was very anxious, but I feel it was one of the wonderful presentations. I loved how you assorted your slide decks, and it was very organized. It didn't look like you were presenting for the first time. Thank you, Dr. Tanveer Kaur. And of course, our own Shishir sir, again, who was very instrumental. It get reminiscent of the flash note days, sir. I think Samiksha is also here, when we all were together in the flash notes during 2020, 2021, during the COVID era. And it's again a homecoming to, have all of us here in a common platform in UC again. With that, I would like to hand it over to Dr. Anujit and Niranjan to distribute the remaining certificates.
You can go ahead, Niranjan.
Yeah, thank you. So it is my pleasure to present the certificate to our esteemed panelists. So Dr. Tanya Jain, thank you so much for joining us today. Dr. Isha Acharya and Dr. Samiksha Agrawal for sparing your time and giving your valuable inputs on today's topic.
I just want to add a few points for Dr. Tanya, Dr. Isha, and Samiksha. Isha was our previous executive member in YOSI, and we have traveled together. And she's one of the dynamic academicians who has published a lot. And thank you, Isha. Thank you, Tanya. Tanya had to juggle between. Thank you, Isha. Tanya had to juggle between another webinar. So again, thank you, Dr. Tanya. She's also doing a phenomenal work in UVA for UC, and Samiksha, I fondly call her mother of twins, and she is one of the most dynamic OYO mothers, and she never says no, and she's always there for academics and UO activities. Thank you, Sam. Again, back to Niranjan, and of course, yeah, I think it's Niranjan. So Niranjan, a few words for Niranjan is, so Niranjan brought in the sponsorships for the academic partner that you are seeing as Microlab is all Niranjan's hard work, along with Anujit, who was instrumental. to be the backbone of this whole event. And Shreya is one of our new additions to the
Sure.
committee. Yeah, Niranjan, over to you.
Yeah, Mr. Kishore, a few words from you before we go
Yeah,
to.
before we'll finish off this. So
Okay.
Shreya is again a new addition to our team, who's again a very dynamic and a promising young ophthalmologist. Anujit has been in the journal club for almost 4 years now. Most of the activities that you saw when I presented, our team, the JC took over just a year or two back, and Anujit was very instrumental in this, going a long way together. And today we have so many activities, and of course Ayushi is also around. And Ritu, again, welcome Ritu. Ritu is again another committee member, our executive. And each one of you should follow her on social media. I do it very vigilantly. I hope each one of you does that. She's again a very eccentric and a very brilliant mind. And of course, last but not least, I am also around to help and mentor you all. So if you guys are looking at this, uh, feel free to reach to any one of us. Feel free to drop a mail. Feel free to connect with Niranjan, Anujit, Shreya, Ritu, who are all here, and we will be able to bring you on the other side. And we are looking at you guys presenting as well. And few words from our academic partner who is helping us with the industry. Niranjan, you would want to call them?
Sure. So it's my pleasure to welcome Mr. Kishore, Micro Labs. Over to you for a couple of words.
Yeah, it's really pleasure to be associated with a young and vibrant team of YOSI. So on behalf of Microvision, Dr. We thank all the speakers. So the turn for the wonderful talk happened today. And so we will continue our association with the YOSI team. Thank you.
Thank you, Mr. Kishore.
Thank you. And before we close, we would also like to thank our designers, Journal Club background people, especially Numerotech, Manjula ma'am, Sai sir, for the seamless uh, uh, work that you guys are doing for the technical support. And yeah, Niranjan, anybody have we missed in acknowledging?
I think also the designing team from Mahatma Eye Hospital, because they're doing a lot of work behind the scenes. Without their support, impossible to have compiled this PPT. Thanks to Mr. Sheikh and everybody, Mr. Prakash, and everybody for helping me in getting together this PPT also. That's pretty much it, sir.
Right. Manjula ma'am, we can go off live. And we'll request everybody to switch on the camera for a mandatory YOSI photograph. So we are photograph obsessed people with the YO sign, and just trying to
Switch on your video and just put up the YOSI sign. I'll just click a photograph.
Anujit, 1 second. Let me just see if I can change my backdrop. I don't
Yeah.
know how it got changed.
So as you do that, I have one sentence though for Dr.
Please,
Tanvir.
please.
Read about specular microscopy and confocal and how it was difficult to map those endothelial cells. And imagine we are now visually mapping retinal cells with adaptive optics. So you're a PG1, you can really relate. It wasn't easy to map out anterior segment, but imagine doing it for retinal cells. It's, altogether like a world of Narnia for ophthalmology. Nothing is impossible here. Great talk, Dr. Tanvir. Yes, sir. You had your
Manjula
background.
ma'am, Sai sir, are we off live?
Then we.
1 second, doctor, 1 second.